Piotr, actually, we will ask you as the next speaker. And you're going to talk about all-comer CAS, cracking the last frontier. Again, PCD scanning for plaque morphology, a game changer in the assessment of the dangerous plaque. So I think there will be a lot of development there.
Thanks so much, Anna, for help.
Perfect.
So thank you to Stephanie for setting the field of, okay, yes, I will. Setting the field with calcium. Calcium is considered the last frontier. So we are back to from a human that is non-alive, but helping to a live human and how to tackle the problem. So this is from space, but nothing is, okay, it will happen. Right, so this is from Krakow. Can we have the voice, the music, the...
Volume is up. Do you have the volume up?
Need the volume. Is it off now? Maybe it's off here.
No, it's here.
We need to stop and get it because otherwise we will...
On my side, it's max.
Can we have the volume? There's volume there. Thank you. Wróć do początku, jak możesz będzie. Dzięki. Right, so any considerations before we start about the calcium? To whom is calcium a limiting factor in the carotids? Who's sending patients to endarterectomy with calcium? Professor Grunwald loves endarterectomy. So.
We would definitely want to assess the plaque. Ideally, microbleeds, ecolucent plaque. So we take that as a big factor also for the choice of device and the choice of protection system.
Professor Matthias, your classic teaching is, you know, if there's a calcific plaque, get away from it.
No, that depends. If the calcification
It's circular.
is dense and circular, then simple angioplasty will not work. But you know, there's different types of calcification. Some is like powder sugar, so that is not a problem. And when it's not circular, but normally it starts at the rear wall of the internal carotid artery, then also you can do an angioplasty and stenting. But when it's circular and stone-like, then you need a different technique, and we will hear now what you do with a little bit of ultrasound.
Good, let's continue.
Thank you.
And we go back to Dr. Piotr Musiałek, who will talk about all-comer CAS, cracking the last frontier.
Thank you so much. Hopefully we'll be able to do the case now together. I really enjoyed the last 3 talks. I have to say sometimes in the extracranial, very tortuous anatomy with an aneurysm, we have problems with entering the distal lumen of the artery. So I'll be very happy to talk to you about the tricks that you use to, sometimes you just, you know, spend time in the sac trying to enter the distal lumen. So we could have the video, please. Right, so this is from Krakow to BEC. We just recorded, you know, one of the cases we wanted to share with you. We didn't know how the case would finish. This is our hospital. Good morning. We are in John Paul II Hospital in Krakow, in Kaplan number 4. With me is Adam Mazurek, who's been investigating highly calcific lesions for several years now. My name is Piotr Musiałek, and with us is also Professor Pieniądze. We have a 57-year-old patient, a lady, who had a left hemispheric stroke 6 days ago. The stroke manifested as severe aphasia, total paresis of the right arm, and partial paresis of the right leg. The patient was diagnosed with a left carotid artery stenosis. The lesion is highly calcific on duplex imaging. So you can see multiple left hemispheric lesions. Okay, so this is the two contralateral projections, the two contralateral angiograms. We can see a severely or very severely calcific lesion in the proximal portion of the bifurcation, and distally a tight, like more normal carotid lesion. So this is a tandem lesion, highly calcific. We can stop here and discuss how to treat the patient. You can see there is a rock of calcium. What to do? Recent stroke, 6 days ago, symptomatic lesion. Does the patient require treatment? That's always the first question I ask myself. Do we need to treat the patient? Can we leave it, Iris? No? No, so we have to treat the patient. So what would you do in Dundee with this patient? Is it the right time for the treatment, 6 days after stroke?
The stroke is not that severe. There isn't such a big deficit, so I would not be that afraid of bleeding. I want to treat as quickly as possible to prevent another stroke.
Yeah, because the patient was IV thrombolized, which means that they occurred in a window for mechanical treatment, definitely. So the first thing I see with this patient that probably the initial window was not used for management, but that is quite often in Poland that we do not get those patients immediately for an immediate intervention. Now, how to treat the patient? We have massive calcium. Can we go back maybe a bit, because this is the images for the calcium. Yeah, here. Who is friends with vascular surgeons? Who's good friends with vascular surgeons in the room? Anyone has friends in vascular surgery? Some people do. So, what to do? Should we stop the procedure now? You think? Would it be unreasonable to send this patient to vascular surgery? What do you think? No, of course. It would be a perfect, good decision to send the patient to surgery. We used to send those patients to surgery. Let's see why we did not send the patient to surgery. Can we have the video back, please? Of course, this is a typical surgical case. High risk for any endovascular tandem lesion, high risk for any endovascular approach. So this is a highly calcific stenosis. There's a way to quantify those lesions, even very highly calcific. The patient had, in 2008, surgery for cancer of the basis of the tongue, and that was followed by radiotherapy. So this is the reason we did not send the patient to surgery. We asked them, of course, do you want to operate on the patient? You know, we don't want to touch the patient. They said, you try endo first. So procedure strategy, double protection, proximal and distal. We can discuss why in a moment. With flow reversal from the external and from the internal. So this is the flow gate balloon going to this catheter in the common. So I will now deflate the balloon. We have proven that we have proximal protection that is operational, that is working, because we've decided we use double protection in this case. You could see the backflow of the contrast, yes? The patient will tolerate flow reversal. This stroke is likely to have had a hemodynamic component, so we want to make sure that then when attacking the calcium, there's also a basket that will pick up the debris, preventing cerebral embolism. I'm trying to cross the lesion under flow reversal, looking for the channel. You see the backflow of the contrast. Yes, this is the protection. Whatever we do with the lesion, it will move back, not go to the brain, the debris. This is not a MoMA case because of the significant amount of calcific lesion towards the external carotid artery. So I would not force MoMA to exclude the external also to have better backflow because of the risk of interfering with the lesion. I would take some support from the balloon. We have an active flow reversal. You can see the blood is coming from the brain here out. Super. So as you see, this inflation is performed under proximal protection. You can see the backflow of the contrast to make it safe. Now we have to make 100% sure that we are in the true lumen distally. So we will inject and reverse, Adam, okay? Reversal. So again, a tandem lesion, kind of highly calcific proximally, and the more normal type of, or usual type of in the distal aspect of the lesion, long, yes, a long lesion. Perfect. Perfect. Okay, so we now know we are in the true channel. You can see the backflow. Yes? And Dr. Mazurek is now delivering the spider filter on which he made a J at the tip of the wire. So double protection because the patient may not tolerate. We are going to perform applications over a certain time of the shock wave energy. This is equivalent to 50 atmospheres. This is a balloon with 2 generators. You see the spikes of the ultrasound energy now, yes, on the screen. Very nicely presented. So this may give some pain to the patient. You're cracking the calcium. You're changing a non-compliant lesion into a compliant lesion. So we are now under double protection.
You see the balloon, and we start again the second application.
This is the sound, you know, the system gives you, the click, click, click. Sometimes the patient has they report some pain or some funny feeling in the neck. So we tell them that this may happen, but normally there is no, because we were initially concerned with, maybe, you know, there will be severe baroreflex response, maybe very low blood pressure, severe bradycardia. This is not happening with carotid IVL in any different way to, you know, standard ballooning as part of carotid angioplasty. The ECG now. This is 40/12 rapid exchange IVL balloon.
No reflect with blood pressure dropped. Now will be number 3. Okay, the balloon is inflated. Application.
So this is series number 3 now.
Number 3.
10 pulses of the ultrasound wave energy. So we combine this with a micronet covered stent. Can we stop here for a moment? So this is a stent that in fact we also use as a flow diverter. We're just finishing a multicentric study in a few countries in the world. This is a very widely open nitinol frame, the most open cell nitinol frame that is currently available. And this is wrapped with a sock, if you like, of micronet. This is PET micronet, making it the closest cell stent available. The idea is to trap the elements of the plaque, to trap thrombus, trap plaque material, trap also in this case this powderized partly calcium, so that you can avoid, you can minimize risk of distal embolism. And this stent is something we've used in all comer patients. You could see this is procedure 900 something. This now we've performed more than 1,000 patients. Sometimes it's bilateral, so about 1,100 cases. Using this device from 2015, we were part of the initial CMARC study, using this in all comer patients. So really challenging the technology, challenging ourselves, thinking, you know, what is the spectrum initially to use the device. We have changed completely, as you will see, the strategy of carotid stenting in this case. So we are not afraid of preparation of the lesion. We are not afraid of appropriate post-dilatation, using 5, 6, 7, sometimes Sterling 80 balloons to really achieve complete lumen reconstruction. And this results in 0 stent thrombosis that we have, and in a minimal risk of instant restenosis, 0.34% in the first 500 patients. Let's move on. Stop here, please, for a moment. So this device has a randomized controlled study. It was tested using diffusion-weighted MRI as the endpoint. That was a pre-specified power calculation against the CREST study stent, because it's the CREST study that set the place for carotid artery stenting for many years. And also DWI embolism is a predictor, is a marker of the risk of symptomatic embolism in carotid artery stenting. So the next available device was the Acculeak stent, open cell stent. And you can see here those dots on your left are the individual lesions. This is a logarithmic scale, as you can see on the left bar. So there's a profound reduction. On the right, you can see this graphic presentation per lesion, so the per lesion, average volume of the lesion, and also the graph on the right, the load of the ischemic particles per hemisphere. So there's a profound reduction with the micronet covered stent. The question we have now asked is, can you further knock it down when you use Lutini proximal protection? Here it was EmboShield NAV filter in both arms, because you had to control for all the elements of the procedure except the type of the stent. Yep. Yep, we move on. As you can see, the stent is flashed, yes. Now, Adam, please show the trick, what we do when we introduce the stent. We introduce also saline here to have backflow of the saline, not to introduce any air in the system.
Now we are crossing the lesion with the stent.
Very easy.
Very smooth passage.
Very easy.
A bit too high up.
Very
Now,
easy.
it
Shows a
see,
40
Adam is
millimeter only stent, not 60 but 40, which is really kind of, exactly what you can get for this tandem lesion, quite long. You can see now the precision of the stent placement. This is like a balloon expandable stent precision. We also use it for osteal subclavians, brachiocephalic trunk interventions, also osteal carotids. So this device can be placed very precisely. There's no foreshortening, no elongation. Yep.
Opening the valve, show it again. I'm pushing contrast through to have backflow of the contrast. Want to beware of air embolism. Air embolism is very symptomatic. It totally resolves usually, but it's important to avoid it. Let's eject.
I don't understand. The valve is open.
So 9 by 40 in this case.
It's
What do you think
okay.
about the position of the stent? Are we okay, Adam?
Perfect.
Happy?
Perfect. Perfect.
But responsibility is mine. Record.
You can still see this calcium there, but the calcium now is changed from non-conformable to conformable. Yep.
Perfect. Okay. Be careful with the filter. Adam is controlling the filter position. Now we post-dilate, we inject, and we post-dilate the stent. So the distal lesion, I think, is covered now. Yes, we covered both lesions. We'll now optimize. Let's open the distal crown. 10. Now, angiographically, the result is good. With this 5.0 balloon post-dilation, we just still optimize the proximal portion of the stent with 6.0. So now we're doing an IVUS run from the distal segment through the stent. You can see that the stent is rounded. It's very nicely opposed. And it's very nicely expanded. So now this is final intracranial angiogram. Perfect.
So you see we've changed the non-conformable to conformable lesion, full endovascular reconstruction of the lumen of the artery. Yeah, we're finished. Yeah, I'm just talking as the video goes on. Video is 7 minutes only. So with optimized protection, IVL calcium cracking, again, change of the non-compliant to compliant lesion, micronet covered anti-embolic stent, full endovascular reconstruction, 7 effective optimal, and also endovascular technique. And with this, I wanted to thank you for your attention. We believe this is a new frontier. Carotid stenting is not only, we believe, equivalent to endarterectomy now, it can get better. Endovascular techniques are progressing rapidly, so this last frontier now, we believe, can be addressed. Yep. You don't stop, please, as I go. Is this the end?
Without any problems, yes? Without any complications?
Just a
Okay,
quick
it's
question
Jan.
to you.
Dzięki jeszcze raz bardzo.
Congratulations.
Dzięki Marek,
And,
dziękujemy Adam,
can
dzięki
you-
Mirka.
And you mentioned about the radial force of the stent comparing the other stent.
It was studied by Christian Wiesgott in Germany, and this is similar to the radial force of the precise stent. So it has, some people say it even has too much of the radial force, but we use it from the thrombotic lesions, also in acute stroke, on the one side of the spectrum, to those highly calcific lesions.
Thank you very much for your wonderful presentation.